but we are going to give you the most important thing in relation to this course and the most important things that will help you in future, either in your future studies for example, in internal medicine, in neurology, or in acute medicine in ER. Okay, so the anatomy of the visual, or the components and the anatomy of the visual pathway. So the optic nerve will start from the posterior part of the globe. Then the optic nerve is a component that will be going from the posterior part of the globe to the chiasm, then the optic tract, then lateral geniculate body, then optic radiation, and lastly occipital lobe or visual cortex. So in this example, I would like you to imagine that this image as if you are seeing your own body. Okay? تخيلوا أنكم you are seeing this part as if you are seeing your own system. بمعنى تخيل أن هذه الصورة is for you. This is your right eye and this is your left eye. تخيل أنها لك. Okay? Not for someone you are examining. If you are examining, this will be the right and this will be the left. Okay? لكن أبغاكم تتخيلون الآن as if it is your own system. Okay? This is your right eye, this is your left eye. So, in the right eye, we will have a nasal retinal fiber, okay, and temporal retinal fiber. Nasal retinal fiber, temporal retinal fibers. The same on the left eye. Nasal retinal fibers and temporal retinal fibers. These fibers will constitute the optic nerve. These fibers will constitute the optic nerve. Okay. These nasal retinal fiber and temporal retinal fiber will go through the optic nerve, and when it reaches the optic chiasm, it will decussate. Decussation, which will happen in the optic chiasm, let's assume إنه هذا decussation is there is an exception, لكن let's take this decussation as if the nasal retinal fiber will cross. Okay? خلينا نقول إنها مجازاً all nasal retinal fiber will decussate to the opposite hemisphere or opposite tract or opposite optic tract, and the temporal retinal fiber from each side will go to the same side, ipsilateral optic tract. Okay, Same in the left eye. Nasal retinal fiber here, temporal retinal fiber here from the left eye will constitute the optic nerve or the left optic nerve. Then in the optic chiasm it will decussate. Decussation زي ما قلنا مجازا there is an exception. لكن at this level I would like you to imagine and to know that most of the fiber, or let's say at this level all the fibers will decussate عشان ما يحصل أي confusion in the future. لكن for the scientific information there is an exception. We will not discuss these exception and it is outside the scope of this lecture. Okay, we agree that the nasal retinal fiber from each eye will decussate to the opposite hemisphere. So let's take this right optic tract. Right optic tract is constituted from the right temporal retinal fibers and left nasal retinal fiber. Okay, right and left. Right temporal and left nasal. Okay, and from the optic tract we'll go to the lateral geniculate body, then optic radiation, and lastly the visual cortex. Okay. This is very, very important to understand this simple chart, to understand the visual field. Visual field or visual field defect is very, very simple if you understand the concept of this one and if you understand the basics of this one. Okay. أبغاكم الآن كل واحد imagine there is an object here. Okay, there is an object here. Let's say this object is here. Okay, I'm drawing this object in this side. Okay, very simple drawing. هذا الobject. Where is the object in relation to me? Okay, or in relation to you? It is on the right side. Is that right? Yes. So this object will fall on the right nasal fiber, right nasal retinal fiber, and left temporal retinal fibers. So this object which is here will fall here and there, will fall here and there. Okay, so this object which is located under my right field will fall on the right nasal fiber, right nasal fiber and left temporal fiber. So it will go to which hemisphere? To left hemisphere. Excellent. It will go to the left hemisphere. Again and again. This object which is located on my right or on your right, imagine as if it is your system. تخيلوا أو can you put any object on your right side, pencil, your hand, your finger, whatever it is, on your right side, and imagine with me that this object is falling on your right nasal, left temporal. Okay, and by default it will go to the left hemisphere. So this object will go to this retinal fiber on the right side, this retinal fiber on the left side. Okay, excellent. Let's take another example. Okay, let's take another example. So this object. Okay, sorry. So let's take this object. This object will fall. What's going on? This object will fall. Okay. Delete. Pointer. Okay, this object will fall on the left nasal retinal fiber and right temporal retinal fiber. So this object on your left side or on the left side will fall on the in the left nasal and right temporal. So by default it will go to the right hemisphere. Clear? Okay. طيب. Excellent. Let's go to the pupil and its common disorders. So in the pupil we have two types of muscles, the iris sphincter and iris dilator. The iris sphincter is supplied by parasympathetic innervation. Iris dilator is supplied by sympathetic innervation. Okay, so iris sphincter in normal steady state, which is parasympathetic. Iris dilator in the fight and flight situation where the sympathetic innervation will be innervated, so the iris will be dilated in the situation of sympathetic innervation. Okay. The pupillary light reflex. So by the way, so we have something called pupillary light reflex. We have something called corneal light reflex, and we have something called red reflex. Okay, don't confuse between these things, because the corneal light reflex, you can do the corneal light reflex by a simple torch or any torch. You shine a light in front of a patient or in front of a candidate, and you see where the corneal reflex will fall. Is it on the pupil, on the sides of the pupil? And you see it directly without, without any location of the, or no need to use the direct ophthalmoscope, for example, as compared to the red reflex. In red reflex, no, we have to use the direct ophthalmoscope, and we have to put it on our eyes to see the reflex. Okay, to see the reflex. And I wish that you all trained on the direct ophthalmoscopy, and you trained on how to use it and what is the uses of direct ophthalmoscopy, because this is very important for your later study. It's not only in the ophthalmology course, but in your later study, those who will go to the internal medicine and in neurology, and those who will be in acute medicine and ER, they have to know how to use the direct ophthalmoscopy. Okay, so the red reflex will use the direct ophthalmoscope to detect the red reflex. In the pupillary light reflex, and in corneal light reflex, no need to use the direct ophthalmoscope. You can use the light of direct ophthalmoscope, or you can use any light. Okay, let's take the component of the pupillary light reflex. Again, this example, as if you are examining someone, you are examining your colleague, you are examining a patient, or you are examining a candidate. You see, this eye is what? This is right eye, and this eye is left eye. So you are examining this patient or this candidate to detect and to check the pupillary light reflex. So if we shine a light, this is a light source, and we shine a light on the left eye, what will happen? So this light will fall in the eye, which composed of nasal retina and temporal retina, right? So these components will constitute the optic nerve. The optic nerve has millions of fibers. These millions of fibers come from the nasal fiber and temporal fiber simply. So these millions of fibers will pass through the optic chiasm. In the optic chiasm, it will decassate, or it will cross which fibers? The nasal one. So it will decassate to the opposite, and the temporal, it will go to the same hemisphere. Okay? It will go to the optic tract, same one from the same eye. It will go to the left or the opposite tract. It will reach where? Here, the pretectal nuclei. The pretectal nuclei. In the pretectal nuclei, it will synapse. Then from the pretectal nuclei, you see this is the pretectal nucleus, and this is the other pretectal nucleus. It will cross. احنا قلنا انها synapse here, then it will cross to both. This one also will cross to both Edinger-Westphal nuclei. Okay, اللي هي third cranial nerve nucleus. Then it will travel from both sides through أو via the third cranial nerve to the ciliary ganglion. Where is the ciliary ganglion? Here. And this is the third cranial nerve. The third cranial nerve usually passes with it اللي هو parasympathetic fibers. Okay, it will travel via the third cranial nerve, then it will reach the ciliary ganglion from both sides. Then from the ciliary ganglion, it will reach the fibers will reach the iris sphincter. So the parasympathetic innervation will reach the iris sphincter and will cause meiosis or constriction of both sides. So again, when we shine a light on the right, it's very important to know the pupillary light reflex also, and how to detect and how to know this is, patent system or system which is affected. Okay, so the light source will be shined on the, for example, left eye. Then the fibers of the optic nerve, it will reach the optic chiasm, then it will decassate till it reach the pretectal nuclei from both sides. Then it will, from the pretectal nuclei, it will synapse, then it will cross to both Edinger-Westphal nuclei. Then it will travel via the third cranial nerve from both sides till it reach the eye sphincter on the left and in the right. And if we do the same on the right eye, it will happen the same scenario. So if we shine a light on one eye, it is constricted, we have to check the other eye whether it is constricted or not. So check whether the afferent system is affected or the efferent system is affected. These, detail of the how to locate or how to know where is the location of the affected system, either in the afferent or efferent. It is very detailed, and it needs, actually it needs lectures to locate the pathology of the affected system, either in the afferent or in the efferent. Okay. So let's take the relative afferent pupillary defects, or what is called Marcus Gaunt pupil. What are the causes of afferent pupillary defects? Either we have optic nerve disease or large retinal lesion. So let's take these two examples, which is, to illustrate and to know what is the meaning of afferent pupillary defect and how to test it and how to detect it. So in this example, we have a normal patient. You see the pupil here, right, left. So then in this, at this level, we shine a light on the right eye. We check the same eye, it is constricted, and the other eye is constricted also. So we put the light on the middle, rests, and both back to almost normal. Then we shine a light on the left eye. We check the same eye, it is constricted, and the other eye is constricted, though this is normal. So let's take another example. We see the pupil, it is normal in both eyes. Then we shine a light on the right eye, constricted. We check the other eye, it is constricted, this is normal. Then we put the light source or the torch on the middle, both back to normal. Then we shine a light on the left eye. What happened? Okay, what happened? So no constriction or no response. So this means this eye has a problem where in transmission of the signal from the optic nerve till we reach the central system for the either in the pretectal nuclei or in the third nerve, and at the level of third cranial nerve nuclei. Okay, so we say this is an affected eye or there's an APD. You remember this one, when we shine a light on the right eye, what happened? This one constricted. This means the efferent system is okay. So we have problem at the level of the left optic nerve, okay, or its pathway. Okay. Any questions so far? ممتاز. لا إله إلا الله. طيب. Okay. So we have something called anisocoria. Anisocoria, very simple. It's pupil of unequal size. This is anisocoria. Anisocoria means pupil of unequal size. So we have miosis and we have mydriasis. Meiosis means small pupil. So the differential diagnosis of small pupil, we have Horner syndrome, or it could be due to pharmacological, like pilocarpine and others. In mydriasis, we have a large pupil. So the differential diagnosis of large pupil either could be due to third nerve palsy, or pharmacological, like mydriatics, cycloplegics, or and so on, or could be due to iris damage, either from trauma, or surgery, or ischemia. Okay, these are the differential diagnosis of meiosis and mydriasis. And there is also a chart and differential diagnosis of anisocoria. We have to test the pupil in normal light. We have to test the pupil in dim light to differentiate whether the chart of differentiating the anisocoria, it's something detailed and outside the scope of this lecture. So let's go to the accommodation reflex. Accommodation reflex, simply when you are seeing an object from far and suddenly you see an object near, what will happen? Okay, what will happen? أو تخيلوا أنكم you are reading or bringing an object near to your face. What are the reflexes that will happen? We have three reflexes. We will have constriction of the pupil, and it has a pathway, but will not go through the pathway. Then the thickening of the lens. Thickening of the lens due to the contraction of the ciliary muscle. Contraction of the ciliary muscle will lead to relaxation of the lens zonule. This will lead to thickening of the lens. Thickening of the lens will help you to read, and it will give you a power lens to read. Then the convergence of both eyes, or both globe, or both eyeball. And these that we mentioned, these are constituting the accommodation reflex. So for me, if you know what is happening, it is very important. The reflex is not important at this level, at least. So we discussed so far the visual pathway and the anatomy of the visual pathway. Then we discussed the pupil and its disorder. What is what are the constitution of pupillary light reflex? So what are the components of these reflex? And also we discussed the ABD. What is the meaning of ABD, and how to test it, how to check it, and importantly, how to check whether the afferent system is affected or no. Then we discussed the anisocoria, either in meiosis or mydriasis, and the accommodation reflex. Now let's go to the motor system, or ocular motor system. So this simple chart or simple picture will help you in understanding the innervation of the cranial nerves, innervation of extraocular muscle by the cranial nerve, and also it will help you in the action of the extraocular muscles. So it's a very simple chart, but it will help you and you will understand the innervation and the action from reading 2 pages in the textbook. So we have, this is right eye, this is left eye, as if we are examining someone. Okay, we have all extraocular muscle is supplied by third cranial nerve, except lateral rectus and superior oblique. So lateral rectus is supplied by 6th cranial nerve, and superior oblique is supplied by 4th cranial nerve. Okay, agreed? Let's take this example. So this is superior rectus, this is inferior rectus, this is lateral rectus, this is medial rectus, this is inferior oblique, this is superior oblique. The location of the inferior oblique and superior oblique, this is only for illustration. Okay, only for illustration of their action. On reality, they are not there. Okay, superior oblique is here and inferior oblique is there. Okay, هذا فقط لتسهيل or to help in understanding the action of these oblique muscles. ممتاز. So the inferior oblique, when reality it is down and superior oblique is up, but the action, هذه الصورة will help you in understanding the action, as in this example. Okay, let's take this one. So what do you think? Which eye is this? Excellent, right eye. Yeah, it's the right eye. Right eye, because this is the medial rectus and this is the lateral rectus. Okay, so في هذه الصورة شباب، في هذه الصورة it will help you in understanding the innervation, the action and location and everything. Okay, this is the medial rectus, this is lateral rectus, this is superior rectus, this is inferior rectus, and this is which one is this? This is superior oblique. Excellent. And this is inferior oblique. Okay, لكن فقط لتوضيح الأكشن of this one احنا حطينا هذه inferior oblique أو هذه schematic picture موجود فيها inferior oblique هنا والsuperior oblique هنا. Okay. طيب. للتوضيح، كل المسلز اللي موجودة هنا are elevator. Okay. وكل المسل الموجودة هنا depressor. والمسلز الموجودة في horizontal line it has mainly one action: abduction lateral rectus and adduction medial rectus. Okay, abduction and abduction. Let's take the recti muscle, the superior vertical recti, superior and inferior. Superior rectus is elevator. Okay, elevator. Inferior rectus is depressor. So superior rectus has also secondary and tertiary action, which is intorsion and adduction. Inferior rectus also has an action of extorsion and adduction. So the oblique muscle, let's go to the oblique muscle. Oblique muscle, the primary action of the oblique muscle is intorsion or encyclotorsion or cyclotorsion for both, and intorsion for superior, extorsion for inferior. So the primary action of oblique muscle is cyclotorsion. Sometimes this cyclotorsion and the action depends on the degree where the primary gaze of the eye is, whether it is 30 degree, 45, 60, is it in primary position, is it somewhere else? The detail of the physiology of the action, where in relation to the action, will not discuss it. لكن you have to know the most important thing, the action. Okay, we agree that the oblique muscles, it has a cyclotorsion. This is extorsion, this is intorsion. What is the meaning of intorsion and extorsion? Intorsion and extorsion. أبغاكم تتخيلوا أو each one of you will bend his head toward his shoulder. Okay, bend the head toward your shoulder. Let's take the right one, right shoulder. Bend your head toward your right shoulder. ما هو يمين ويسار لا. أبغى كل head toward the shoulder. Okay, كل head toward the shoulder. There will be a movement on your right eye, and there will be a movement on your left eye. The movement on your right eye, when you bend your head toward your right shoulder, what is happening? There will be a movement like this. Cyclotorsion. In toward the nose, toward your nose. This is intorsion of your right eye when you are bending your head toward your right shoulder. This is what we call the intorsion. And what is happening to your left eye when you do this one? So your left eye will be rotated outside. Okay, will be rotated outside. So we call that one as extorsion. So this is the action of superior oblique, the intorsion, and the action of the inferior oblique is extorsion. Okay? It has also the oblique muscle, it has the action of elevation and abduction. Also the superior oblique, it has an action of depression and abduction. So from this chart, you can understand the innervation and action of the all extraocular muscles. Okay. بس عشان you remember how to memorize the either is it adduction, is it abduction, because sometimes it is confusing if you don't know the action in detail. هذه lateral rectus is abduction outside, it's abduction. This is adduction. المسلز اللي موجودة هنا on the same side, it is opposite to the abduction. This is adduction, this is adduction. هذه بس يسهل لكم حفظ الأكشن، مع إنه what I advise you is to understand it. لكن هذه تسهيل حفظ الأكشن. This is abduction, so these are opposite to it. ومكانها موجود هنا السوبيريور معناتها إنها elevator. أوكي، وهذه مكانها هنا معناتها إنها depressor. So هنا adduction، هنا adduction عكس lateral rectus. Same scenario here. This is adduction, so the oblique are abductor. So one more trick. All superior are intortor. Okay, all superior are intortor, all inferior are extortor. Okay. هذه أيضا one more trick for the عشان يسهل لكم حفظ الأكشن حق الإكستراوكولار muscles. Okay. وفي هذا التيبل فيه كل الديتيل اللي ذكرناها، لكن مجمعة بطريقة على شكل تيبل في نفس الصورة. Let's go to the cranial nerve pulses. Cranial nerve pulses. So we have oculomotor nerve palsy or third cranial nerve palsy. So what is the action of what are the muscles supplied by third cranial nerve? We just mentioned it, the muscles supplied by third cranial nerve. Yes, all except lateral rectus and superior oblique. Correct. So أبغاكم تتخيلون الأكشن. Yes, correct. أقول except lateral rectus and superior oblique. أبغاكم تتخيلون الأكشن. What will happen if we have third cranial nerve? So we will have ptosis, hypotropia, and exotropia. Why ptosis? Why ptosis? Yes, orbicularis oculi. Correct. Why hypotropia? Why hypotropia? Because of overaction of superior oblique. Excellent. Overaction of superior oblique, or the domination of the superior oblique muscles, which is supplied by fourth cranial nerve. Why exotropia? Again, yes, because medial rectus is affected, so the lateral rectus will be dominating, or it will be overacting. Okay, excellent. So let's go to the example. This example is a common example which I am bringing always. So this patient came to the clinic. Let's take the الإكزامبل اللي في أسفل الصورة في أسفل السلايد. This patient came to the clinic. He's 70-year-old, diabetic, hypertensive. Came to the clinic. He is noticing that he cannot open his left eye. نقول لك في الكلينيك دكتور أنا حاولت أفتح عيني ما قدرت، حاولت أرفعها I can see. This is the trick. بيقول لك حاولت أرفعها I can see. Okay, we examine a patient and we find this. So this is, you see this dot? You see this dot? This dot? This is what we are calling the corneal light reflex. Corneal light reflex. When you open the eye, what we find, or what we will find in such patients, you see the reflexes here. So he has complete ptosis. He had exotropia, and excellent, he has also mydriasis. And he has also mydriasis. So these signs are not always typical in all patients. We might have complete or incomplete. We might have complete third cranial nerve palsy, and we might have incomplete palsy. It's not necessary to find all the typical signs there. So let's take this example also, the one in the upper lecture. To examine a patient with nerve palsy, especially the vertical or oblique, you have to test what we call the 9 gaze. What we call the 9 gaze. For the horizontal palsy, in the one in primary and one in the right and in the left is enough. For example, for the lateral rectus or for the sixth cranial nerve. But for the vertical and oblique palsy, we have to test the 9 gaze. Okay, this is the primary position. Okay, this is the primary position. And as you know, the pictures and the presentation not always typical. So sometimes there is, variation in the presentation of in these patients. So this is the primary position. We ask the patient to look right. You see, the left eye is not moving to right. We ask the patient to look left. Okay, acceptable, and almost he's looking left completely. We ask the patient to look up. There is very, very little movement. Okay, we ask the patient to look down. Very minimal movement, almost to none. We ask the patient to look up and right, down and right, up and left, down and left. Okay, so this patient has limitation of adduction, subduction, infraduction. Okay, and if you notice here in the primary position, there's a mild ptosis as compared to the right eye. Okay, as compared to the right eye, you see the space between the space, what we call the scleral shore. There is also a mild ptosis. So this is third cranial nerve palsy till proven otherwise. Okay, third cranial nerve palsy till proven otherwise. So there's some guidelines for the workup, what to do in such cases. In these patients, if the pupil is involved, we call it, the most people, they call it surgical third nerve palsy, but we can call it, pupil involving third cranial nerve palsy. In these cases, we have to do MRA, magnetic resonance angiography, and if normal, we have to do catheter angiography. Why? To rule out aneurysm or compression. So in the cases of pupil involving third cranial nerve, if you imagine in the beginning of the lecture, we mentioned that the parasympathetic innervation will go through the outside, through the outside fibers of the third cranial nerve. If there is aneurysm or compression, it will compress the lateral side. This compression will lead to ischemia of vasa nervosa of the parasympathetic fiber, leading to pupil involvement. And usually, and more importantly, the thing that we have to rule out, as someone just mentioned, is posterior communicating artery aneurysm. Okay, posterior communicating artery aneurysm. And usually this aneurysm, you remember from your anatomy, and this is very, very important, very, very important for your future study, is to know this as a surgical third nerve palsy. What is the thing that you have to rule out? What we call it posterior communicating artery aneurysm, or the common name اللي هي يسمى السيربرال aneurysm. السيربرال aneurysm تسبب أو might lead to the acute third cranial nerve palsy. Okay, يسمى posterior communicating artery aneurysm. You know the location? Usually هو بالجنكشن ما بين the posterior communicating artery and internal carotid artery. Okay, and this is a life-saving if you detect such aneurysm. Okay, let's go to the fourth cranial nerve palsy, or trochlear nerve palsy. So what we'll find, ipsilateral, same side, hypertropia. اوكي، هذه الهايبرتروبيا لها characteristics. هذه الهايبرتروبيا لها characteristics increases in opposite or lateral gaze, increase in opposite or lateral gaze, and on ipsilateral head tilt. On ipsilateral head tilt. These patients with trochlear or fourth cranial nerve palsy, they will have a special or special compensatory head position. They will have chin down, face turned to the opposite side, and head tilt to the opposite shoulder. كل هذه الcompensatory head tilt and head position, they are trying to avoid diplopia, because most of these patients in acquired fourth cranial nerve palsy, they will have this position, or even in congenital, okay? So they are trying to avoid the diplopia by this position. The most common cause or the most frequent cause of the fourth cranial nerve is trauma. In the presence of no trauma, isolated fourth cranial nerve, usually it is vasculopathic, either due to blood pressure or blood sugar, which is either hypertension or diabetes. So, and in any cranial nerve palsy, you have to check and you have to test the patient for other neurological signs. Let's take this example. So in this patient, this is the primary position. You ask the patient to look right, to look left. So, to look up, to look down. So in this example, there is very little, or if you imagine this one, it is slightly hypertropic, okay? It's slightly hypertropic. We ask the patient to look to the opposite side, okay? To the opposite side, it is slightly elevated, okay? It's slightly elevated. We ask the patient to the left side, almost it's okay. We ask the patient to look up and right. There is overshooting here, okay? There is overshooting here. We ask the patient to look down and right, down and left. Then we have to do what we call it the head tilt. We have to do the head tilt. Okay? We have to do the head tilt, the right head tilt or the left head tilt. The right head tilt and the left head tilt. So the right head tilt will be here and the left head tilt will be here. So on the right head tilt, there is nothing and there is no overshooting, or it is normalized. So in the left head tilt, there is slightly increasing in hypertropia. So we call this one in the opposite head tilt, in the ipsilateral head tilt, there is increased hypertropia. زي ما قلنا هنا إنها هذه الهايبرتروبيا increase on lateral gaze and on the ipsilateral head tilt, as in this example. Increase in the opposite gaze and ipsilateral head tilt. So this is most likely a fourth cranial nerve palsy till proven otherwise. Okay, there is a very special test which we call three-step test to detect the vertical cranial nerve palsy or the vertical palsy. So first we have to determine what we call this Bolshevsky three-step test. And the first step of this one is to determine the side of hypertropia in primary position. Okay, then we determine if the hypertropia number 2, the step 2 or number 2 is determine if the hypertropia increases in right gaze or left gaze. And the third step of the test is to determine if the hypertropia is worsen on the right or left head tilt. So, and there is a chart to draw in determining which one is this, which one is included, which one is not included in the vertical cranial nerve palsy. So, in conclusion of the fourth cranial nerve, usually, as in this example, for example, in the left fourth cranial nerve, the patient will have left hypertropia in primary position. This hypertropia or left hypertropia, it's worse in the right gaze, and this left hypertropia worse in left head tilt. This is the conclusion of, or the pearl of fourth cranial nerve palsy. And there is also differential whether these are the congenital or traumatic or acquired, لكنها outside the scope of the lecture. Those who will go to the ophthalmology and later for neurology, you will take these signs and to detect it in detail. Let's go to the sixth cranial nerve palsy. So it is very simple. What is the finding? We'll have ipsilateral loss of abduction, or inward deviation, So this is an example of what I just mentioned to you, the horizontal gaze palsy. In horizontal gaze palsy, it is not enough to bring only one picture. Okay, it is not enough to bring one picture. So we have to bring the right gaze and left gaze. This is the primary position. We ask the patient to look right, we ask the patient to look left, and there is a limitation of abduction of the left side. So this is left sixth cranial nerve palsy. Okay, so in isolated sixth cranial nerve palsy, children most often boast viral and usually to resolve over weeks. Sometimes it is associated with ear infection or otitis media, and sometimes we have to consider tumor or trauma if it is not typical or if it is associated with other neurological signs. In adults, usually the sixth cranial nerve palsy is vasculopathic, or could be due to tumor or trauma. And sixth cranial nerve, is the most vulnerable, cranial nerve in the cavernous sinus to trauma. So in the cavernous sinus, the most vulnerable one is the sixth cranial nerve. So These are the things that you should know. And as compared to the head trauma, the most vulnerable one is the longest one, which is the fourth. Okay, so in the cavernous sinus, the trauma is related to the sixth cranial nerve. Let's go to the other cranial nerve palsy, the trigeminal nerve and facial nerve. Trigeminal nerve divided into three divisions: ophthalmic, maxillary, and mandibular. And facial nerve, in the facial nerve palsy, as you know, the seventh cranial nerve will supply the orbicularis oculi muscle. If there is a palsy, there will be a lack of thalamus with inability to close the eyelid. Okay. So we just finished and mentioned the ocular motor system and cranial nerve palsy, and the cranial nerve palsy, third cranial nerve, fourth cranial nerve, sixth cranial nerve, and we just touch upon the trigeminal and facial nerve. So let's move to the optic nerve disease, and lastly the visual field. Okay. Position in third cranial nerve palsy is due to levator palpebrae, usually the superior division. Usually the superior division of the third cranial nerve is affected. Okay, so let's move to the optic nerve disease. When we have optic nerve disease, there is something called mechanical sign and something called vascular signs. In the mechanical signs, we have elevation, blurring of margin, peripapillary edema, and choroidal folds. These are mechanical signs. And we have vascular signs, which is hyperemia of the disc, venous dilation and tortuosity, disc hemorrhage, nerve fiber layer infarcts. It's not obvious in this image. And the exudates. So these are the signs of optic nerve affection or optic nerve disease. If you compare this disc to this disc, which is normal looking disc, and by the way, this is the right eye, this is the left eye. Okay, just for your information, this is the right disc, and these are the arcades going toward the temporal side, and this is the arcade toward the temporal side. So usually the arcades are directed toward the main arcades are directed toward the temporal side, or usually the macula almost always temporal to the disc, or the disc always nasal to the macula. اوكي، هذه أنا يعني ما راح تنسألون فيها، لكن this is something that you should know, or this is for your information if you pass by an ophthalmology course. So let's go to the causes of disc swelling. It could be due to increase intracranial pressure. It could be due to ischemic optic neuropathy, optic neuritis, malignant hypertension, central retinal vein occlusion, nutritional optic neuropathy, toxic optic neuropathy. Could be due to tumor infiltration, orbital pseudotumor, or thyroid orbitopathy. These might cause optic disc swelling. It might lead to one of the signs that we have just mentioned. Let's start with, or let's take some of these diseases like papilledema. Papilledema is defined as disc edema due to increased intracranial pressure. This is papilla edema. And I would like you to differentiate or to name things correctly. For me, if you see a disc swelling and you mention this is a disc swelling, I'll be very happy. Apart from mentioning any disc swelling as papilla edema, not all disc swelling are papilla edema, because papilla edema has a definition. It's a disc edema due to increased intracranial pressure. And papilla edema, on the other hand, usually it is bilateral. Usually it is bilateral. Okay, usually it is bilateral. So if you see a disc edema and it is unilateral, you shouldn't mention this is papilla edema. There is extreme rare exception and extreme syndromic diseases that will lead to only one disc edema, and still we call it papilla edema. We call it foster Kennedy syndrome. And this syndrome, patient will have papilla edema from the start, and he will have chronic papilla edema. This chronicity, due to the nature of the disease, will lead to atrophy of the nerve fibers. These atrophy will be manifested in one side with the recurrence of the papilla edema or recurrence of the increased intracranial pressure. The affected side will have pale disc, and the other side, if he has an acute on top of chronic, he will have a disc edema. So, but we'll take the general and most common presentation. So in these patient will have disc edema, loss of spontaneous venous pulsation, transient visual obscuration, diplopia. These patients will have normal color vision and visual acuity and normal pupil. So what are the differential diagnoses of papilla edema? Either due to intracranial tumor, either could be also meningitis, either infectious or carcinomatous, could be due to idiopathic intracranial hypertension, which is the most common cause in some age groups. We call it idiopathic intracranial hypertension or pseudotumor cerebri, which is papilla edema with normal neuroimaging and cerebrospinal fluid. How to diagnose it, or what are the workup to do? We have to check the blood pressure to rule out the malignant hypertension. We have to do brain neuroimaging, and if there is no mass on neuroimaging, we have to do lumbar puncture. Okay, we have to do lumbar puncture to prove this is increased intracranial pressure. This is correct, but it is not absolute contraindication if there is no mass. Okay, if there is no mass, this is absolute contraindication if you don't do neuroimaging. This is completely true. It is contraindicated to do it in ER before doing neuroimaging. But if you do neuroimaging and there is no mass neuroimaging, you can perform lumbar puncture. Okay. So let's move to the optic neuritis. Let me see how there is an increase in ICP. I didn't get your question. How there is an increase in ICP, the intracranial pressure. It'll be in case of increased intracranial pressure is absolute contraindication, isn't it? And I think we answered this question. It is not. It is correct. You are correct. It's absolute contraindication if you don't do neuroimaging. Okay. If you do neuroimaging and there is no mass, you can perform lumbar puncture. Excellent. So let's move to the optic neuritis. Optic neuritis simply is an inflammation of the optic nerve, either idiopathic or associated with systemic diseases. In systemic diseases, when there is a multiple sclerosis, the female are more common than male. What we will find, the patient will present with acute unilateral visual loss. There will be pain with eye movement, decreased color vision, ABD, and visual field defects. These are the typical signs of optic nerve diseases, especially if it is, optic neuritis. So the differential, either it is idiopathic or due to multiple sclerosis. And in multiple sclerosis, you pass through the medicine neurology, and you have, already you study the presentation detail of the neuroimaging signs or neurological signs of MS. So in optic neuritis, the most important thing that you should know, optic neuritis can present either papillitis, which is the optic disc head or optic nerve head, or retrobulbar optic neuritis. Retrobulbar optic neuritis, which is commonly associated with MS, patient will present to you in the clinic. If you examine a patient, he will have or she will have a normal looking disc. Normal looking disc in cases of retrobulbar optic neuritis. So we have to examine the patient carefully in relation to his symptoms and in relation to the most common differential diagnosis. So the patient might have very minimal or moderate visual loss. Patient will have usually normal looking eye on slit lamp examination, but if you do pupillary exam, if you do visual field, if you do color vision, you will detect that he might have retrobulbar optic neuritis. And when you do neuroimaging, MRI with contrast, you will see the finding of optic neuritis or enhancing of the retrobulbar part of the optic nerve. So let's move to the last topic of today's lecture: visual field defect. In the beginning of the lecture, we just mentioned, and we know how to, or we understand the location of any object in relation to our system. Same example. Here we have this object, this part will fall on right nasal, and this part which is coming from will fall in the right temporal. Same scenario here, and this object mainly will fall here, right nasal, left temporal. Okay, and the nasal retinal fiber, we agreed that it will cross to the opposite hemisphere, and the temporal retinal fiber will stay the same on the ipsilateral hemisphere. Okay, so this is the right eye, this is the left eye. So let's start with these examples, then we'll highlight the things that is important to you at this level. So in the first example, you see the disease. Where is it? There is complete dissection of the left optic nerve. What we will have, we'll have a blind defect. In the second example, we have binasal hemianopia. Binasal hemianopia. Okay. Binasal hemianopia means patient can see the things on the temporal side, but he cannot see the binasal, the binasal field here. Temporal side he can see it, but the nasal binasal hemianopia, and the more common and the most common visual field defects in cases of pituitary tumor or pituitary aplaxy is the things what we call the bitemporal hemianopia. So the bitemporal hemianopia, in bitemporal hemianopia, patient will have which fiber affected? Nasal fiber. So the nasal fiber, the nasal fiber will receive the image from temporal side. So anything in the temporal side, here and there, it will be affected. So the patient will have bitemporal hemianopia. So in example number 4, with the diseases located here in the left, on the left optic tract. So what are the components of the left optic tract? Left temporal fibers and right nasal fiber. So what will happen here in relation to the optic, in the relation to the field defect? Patient will have right homonymous hemianopia. Okay, right homonymous hemianopia. Clear? Why? Because he has affected left temporal retinal fiber and right nasal retinal fibers. When you move to the example number 4, we will have a right homonymous superior quadranopia, right homonymous superior quadranopia, أو اللي يسموها pie in the sky. Pie in the sky, right homonymous hemianopia means there is location of the affected affected sides, the left Meyer lobe. Meyer lobe lesion will lead to right homonymous hemianopia. Then we have the visual radiation, the superior visual radiation. We will have the inferior quadranopia, and lastly, in the visual cortex, we will have a homonymous hemianopia with macular sparing. It will be very obvious when we do a Humphrey visual field that the macula is spared, and it is not always, and there is a theory behind it. So for me, if you understand the basic concept of visual field, how it is presented, and what is the normal field that will constitute the image, and knowing the concept or these examples is more than enough for me at this level. And knowing the more importantly, the bitemporal hemianopia, by in the sky. This is a very common example or very common question in international exam, which is the homonymous superior quadranopia or by in the sky, which constitutes the Meyer loop. يعني ما هو شرط إنه يجيكم بالاختبارات will not come to you, لكن this is a very common example and very common exam question internationally. If you go to either in the exam or in USMLE or Kaplan or Canadian exam. So these are the common questions in relation to the visual field. So by this, I would like you to thank you all for attending the lecture, and I'd like to thank all your questions and feedback. If you have any question, most welcome. So we'll have 2-3 minutes for question, then I'll leave you for the next lecture. What is the differences between optic disc swelling and cupping? Okay, optic disc swelling. So let's go back to the same picture. You see, this is a disc, normal looking disc. Okay, here, and this is a swelling. The whole disc is a swollen. Disc is swelling. In the optic nerve or optic disc cupping, بيكون هنا فيه زي cavitation inside the disc. I wish I have a picture for the cupping, but I think you gone through the glaucoma lecture, and there is also a very beautiful picture, I think most likely in the glaucoma lecture. So the cupping, these cavitation inside the disc, but in the optic disc swelling, the whole disc is swollen, completely swollen disc, as compared to the normal looking. This is a normal looking. If you compare this one to this one, this is completely abnormal. In the optic disc swelling, though, in this type of patient, the optic disc is the cupping is almost non-existing. Is it always that optic disc swelling? No. Optic disc swelling mean optic disc edema? You mean babble edema? قصدك babble edema يا علي؟ I didn't get the question. Edema in general. This is the optic disc swelling. Optic disc. I didn't get your question, Ali. Optic disc swelling equal to optic disc edema. Yeah, مجازا yes. لكن babble edema has a definition. هذا هو تحفظي على هذا definition. Although there is في variation ما بين ophthalmologists و neurologists in relation to this definition. حتى in between ophthalmologists. لكن babble edema by definition it is disc edema due to increase in intracranial pressure, and by definition it is bilateral. Excellent questions and feedback. Any question? Feel free to ask any question. any question, even if you feel it is something not important or something trivial, because any question is very, very important to understand even one point that is not clear to you. When there is a muscle nerve palsy, okay, the muscle move to the opposites of its action. Not always عبد المجيد, لكن if there is an overaction or if there is a movement, yes, but not always to the opposite of its action. It's not, ما نقدر نقول إنها common rule. Sometimes yes. If you'd like to describe a fundus view, can I use the two words optic disc swelling and edema? Yes, مجازا yes, but don't mention babble edema. What I prefer disc swelling. What I prefer is disc swelling. It is more generalized and more scientific. More generalized and more scientific. You can mention the signs, Ali. You can mention I'm seeing. If you'd like to avoid these or you exchange the terms with something else, you can use the description. Describe it. There is hyperemia. There is venous tortuosity. There is disc hemorrhage. There is elevation. There is blurring of margin. These are the things that you can use exchangeably. Like if you mention that I'm seeing or suspecting a disc edema, a disc swelling, this is completely right. This is completely right. Loss of spontaneous venous dilation. As you know, 20 to 25 to 30% of patients or people, they will have, when you examine their fundus, when you examine their disc, you will find and you will see the venous pulsation. It is normal. You will see the venous pulsation or the pulsation of the venous pulsation on exam. So mentioning that loss of spontaneous venous pulsation, you have to see the patient from the start. Suppose this patient is following with you, or this patient was referred to you from any specialty, and they would like you as an ophthalmologist to examine his fundus and to comment on his disc. In the beginning, if you are seeing the venous pulsation, you document it in your exam, and with time the patient case or the patient disease progressed, and the follow-up you notice that this venous pulsation is absent. At this stage, you commented that there is a loss of spontaneous venous pulsation, but we don't comment on the venous pulsation of any patient if it is absent. This is abnormal. No. Excellent. I'm happy to answer any questions more. Any question. طيب, with this, and I will give you a time to have a a break and to prepare yourself for the next lecture. And